Hi, everybody. This is David Nevins for Citybiz List, and welcome to our program today. Today we have a special guest, and he is Dr. Paul Gurbel, and he is the director of the Center for Thrombosis Research at Sinai Hospital of Baltimore. Quite a title there, Dr. Gurbel. Welcome to our program.
Thanks, David. Great to be with you today.
Oh, it's our pleasure indeed. So, Doctor, tell us about the mission for the Sinai Center for Thrombosis Research. I know you are one of the country's busiest interventional cardiologists, and this is an important project of yours. So share some of the details with us, if you don't mind.
Thanks, David. So thanks for the opportunity. Well, the Center for Thrombosis Research started at Sinai Hospital in 1997, and it really began with the investigations of what happens to blood platelets during coronary interventions, during stent implants. So very early on, when the stents came to the fore, we had problems with blood clotting inside the stents. And so our laboratory began studying actually the blood for its clotability. And we began studying the efficacy of the drugs given to patients to block this clotting process. In 1997, in the mid-1990s and early 1990s, when the stents first came out, blood clotting was one of the major complications of putting a stent in the heart. So in the 1990s, we began studying one of the most widely used drugs to prevent this, given to patients to prevent this problem, which was Plavix or clopidogrel. And we noted, quite shockingly, that about 30% of the patients who got a stent put in their heart, who were relying on the antiplatelet effect of Plavix to prevent this catastrophic clotting in the stent that was just put in their coronary artery, actually were not getting a good, what we call pharmacodynamic effect. So we looked at their blood in a test tube in my laboratory and actually looked at how well the platelets were blocked. Only about 70% of the population was getting what we called a good pharmacodynamic effect of the drug. So that was a real epiphany. And that led to further studies by our group, clearly linking this poor platelet inhibition to subsequent blood clotting events in stents, heart attacks, stroke, and even cardiovascular death. If you fast forward a decade or so after our first description of this problem, work has been done around the world that really validates this link between an insufficient platelet inhibition and cardiovascular risk of clotting. This led us to develop drugs that were better than Plavix, that could provide more uniform, predictable antiplatelet effect. And one of the drugs that we played a key role in developing is Brilinta, also known as ticagrelor. And this drug has been shown to have a superior pharmacodynamic effect to Plavix. We demonstrated this. And in fact, our studies are included in the package insert of Brilinta that is now available worldwide for use. So we're very proud of how our research has led to a new drug that has led to improvement in survival in patients with coronary disease and lessen the risk of blood clotting. And it all started back in the late 1990s when we first began studying what actually happened to the blood platelets when a stent is implanted in the heart, and the efficacy of the workhorse drug at that time, Plavix, which was used to prevent this devastating problem. So that's one aspect of the research we're doing. We call it translational research because we measure the effect of a drug in a ex vivo outside of the body, and then we link that to clinical events to try to improve upon what we see in a test tube to provide better inhibition of clotting, better inhibition of platelets, with the hope of improving patient outcomes.
Let me just now. Ordinarily, this world-class research that you're talking about, isn't it usually associated with a major academic medical center? How did you build this world-class institute at Sinai Hospital?
Well, thank you. That's a great question. When I came to Sinai Hospital, I was recruited by Bart Chernow in the late 1990s. He was then chief of medicine. He was a professor at Hopkins, and he offered me his laboratory space. And I was then at the University of Maryland Hospital. I had just come up from Duke, where I had learned a lot about blood clotting and treatment of clots. But I realized soon that very early on that you could do great translational research in a high volume hospital. So at that time in the late 1990s, we had an extremely busy catheterization laboratory, a robust cardiac surgery team, a robust cardiac surgery program. So this was an ideal place really to do this kind of work, David, where you had lots of patients in the cath lab, you had access to the patients, and we had a world-class basic laboratory that we set up. It was the perfect combination to study effects of drugs on patients with heart disease, and a perfect setting to develop new drugs. So it was a perfect mix. And I would submit to you that this is one of the best types of environments to do this kind of work. We're not in a major university that has a lot of hindrances in terms of its ability to move quickly, to be nimble, and we didn't have to confront that so much as we would say at Duke University, where I had been before, or University of Maryland. Not to say anything negative for those institutions, but a lot of the bureaucracy and other hindrances we really didn't have to deal with at Sinai. We could move more quickly. We had a rapid turnaround in our IRB, and we could get studies done very quickly. So that made for a really nice environment for us. Of course, we collaborated with so-called academic leaders. These would be people in universities around the world on our research in England, in the Netherlands, in Poland, in Israel, in Korea, in China, who have actually come to our lab to learn how to study platelet physiology and how to do translational research and clinical drug development. So we do a lot of collaborating with academia, and we're very fortunate to have that nice relationship with them.
That's a great segue, Dr. Gurbel. I know that you are, as noted, a world-class researcher who's highly sought after as a speaker at national and international conferences, and then yet at the same time you're one of the busiest interventional cardiologists in Baltimore, if not on the entire East Coast. How do you? That's an odd combination, right? Because most doctors in your position choose one or the other. How do you balance the two? Let me ask.
Well, you have to love what you do, and so God's blessed me with being in a job that I really love what I do, and I love the team we have in the research lab. So for me, it's fun. And I was in the cath lab today. I think you can probably still see the mask marks on my face.
Yes.
I just got out of there, and it's just a lot of fun to see how the new technologies that we have now to treat coronary disease, that's my super specialty, is catheter-based treatment of coronary disease, how we've really come along and in a fairly short period of time to really improve patient outcomes. Today, I did a procedure on a patient who had a very heavily calcified artery that required a shock wave to actually open up the artery to allow a stent to go in. So this would be dreamland, 20 some years ago, but we're actually using almost like lithotripsy in the coronary arteries to get arteries open now. And if you told me we'd be doing this maybe 15 years ago, I'd say you got to be kidding me. But to actually have the tools available to really help patients is very rewarding. So it keeps me active in that. And we have a very good research team that's committed. And we've been working together for 2 decades now. And I don't see us slowing down anytime too soon.
That's really good to hear. And in addition to your work at Sinai, you're a Baltimore guy, I know, and I think our viewers should know that you were recently recognized by Johns Hopkins University. You received their Distinguished Alumnus Award, so congratulations on that. Talk a little bit about your Baltimore roots. You've decided to stay in Baltimore and make this the hub of your research, in addition to the hub of your practice. We hear way too often folks who, for whatever reason, choose to leave Baltimore. So tell us why you're still here and doing what you're doing.
Well, I love Baltimore, and my family, both sides of the family, were from Baltimore. My mom and dad's family, they were children of Polish immigrants. So they grew up in Fells Point. And I was fortunate enough to go to a really good, solid prep school, which really started me on the way to know how to study and to know how to read books and to know how to speak, and taught discipline. I went to Loyola Blakefield, and I would have to credit a lot of my success to experience I had there, laid the groundwork and built a lot of loyalties for me in the community through my interactions and my experiences at Loyola. And then I went to Hopkins, and that was my first choice for university. And it was provided a really solid research experience for me. And when I was at Hopkins, I was thinking about doing study for PhD in basic science. And I was working with a professor at the medical school, Subroto Chatterjee, who was a mentor in the medical school at Hopkins. And he convinced me at the last minute to think about medical school. And he said, as an MD, you can do the same kind of research you can do as a PhD, but you have a more global picture of where your research should go and where it's most applicable. And that really did it for me. So it was my experience at Loyola, at Hopkins, and my work with Dr. Subroto Chatterjee when I was a really young guy that really got me on the right path. And a lot of it, I think, is luck, but a lot of it isn't luck. And I was very fortunate to have those experiences at a young age that really got me on the way.
It's our good fortune as well that you've had those experiences and chosen to stay here to not exclusively, but primarily to treat Baltimoreans. Paul, we only in just a couple minutes that we have left. I know you're excited about some of the next steps, new projects that you and your team at Sinai have planned. Just rather briefly, if you don't mind, I know that's hard because you're so excited about it. Share with us a little bit of that.
Thanks. Well, speed is really important when you think about treatment of heart attack, right? When you have a heart attack, you have the development of a blood clot in a vital artery in your heart. So we've been involved in developing drugs that are fast and provide a predictable inhibitory effect on platelets. Platelets are the cells that stick together to block the artery. So we helped to develop Brilinta, which I told you earlier provides us better, faster antiplatelet effect than platelets. So right now we're working with 2 drugs. One drug is an injectable drug. It's an injectable drug that works similarly to Brilinta, but the goal is to have patients who have high risk heart disease have this sort of like an EpiPen if you have allergies. So if you get bitten by a bee and you have anaphylaxis, you just shoot the EpiPen. Same thing if you have a heart attack and if you feel like you're having chest pain, having a heart attack, you have a history of heart disease, you inject yourself with this drug that provides rapid platelet inhibition. It's called selatogrel, and we're involved now in a phase 3 trial to develop that drug. And we actually did the early drug development on it before it is now in this large clinical trial. And the second thing we're really excited about, David, is our work with inhaled aspirin. This is a new potential route to speed the platelet inhibitory effect of aspirin. You know, I was on the Dr. Oz show before he was running for any government position, talking about how it's important to chew and swallow aspirin to get the most rapid effect of aspirin. If you feel that you're having chest pain, you may be having a heart attack, the best way to get the drug into the circulation is to chew it and swallow it. So now we're looking at the inhalation route. And we're actually in their early studies, which were recently published in Circulation, we showed in healthy volunteers, you can speed up the time, shorten the time of the platelet inhibition by aspirin by actually inhaling it. It's a special type of aspirin. It's a nanoparticle aspirin delivered through an inhaler. So we don't want patients to, crush their aspirin and inhale it, of course. This has to be delivered through a special device. But we're really excited about this, and we're now involved in a larger early phase trial where we're actually dosing healthy subjects with aspirin in our research laboratory through the inhaled route. So we're excited about this. All this has to do with upfront therapy, upstream therapy, so that the therapy is in the hands of the patient with heart disease, so they can deliver potentially life-saving therapy before they come when they're en route to the hospital or getting ready to call the ambulance 911. They can implement potentially life-saving therapy at home.
I'm kind of excited. I know you once said to me that everybody should have a couple baby aspirin in their wallet. So that, but I'm now excited in the not too distant future, there'll be a more efficient means of getting it in one system.
We're excited about it. We have a long way to go, but we've shown proof of concept that it can be done in healthy volunteers. It is tolerated. There is some coughing. And I suspect that the formulation will change to make it more user-friendly. But this is an exciting new way to deliver drugs when the drug needs to work quickly and potently early on. And I think the inhalation route is an exciting new way to deliver cardiovascular drugs. And in fact, some are on the market right now.
Let me just ask you this. I don't get an opportunity to talk to cardiologists all that often, fortunately. No offense. And probably our viewers don't get that opportunity either. So before I let you go, and because we're kind of at the end of our time, this is a very basic question. You'll be able to easily answer it, but give our viewers 2 or 3 tips on how they can what will contribute to the maintenance of a healthy heart and cardiovascular system. I'm sure every one of your patients asked you that, so everybody can get a freebie here if you don't mind.
Well, the first rule would be make sure you have a good relationship with your doctor and that you regularly see your doctor, your primary care doctor, at the intervals recommended. So that's the number one thing. The second thing is to know your body, to know your blood pressure, to know your numbers. We talk about this very frequently at LifeBridge. In fact, there's an effort on behalf of LifeBridge to get people to know their numbers, to know their cholesterol, to know their blood pressure. You have to absolutely know your numbers. And the third thing is healthy lifestyle, exercise, stay lean, and have a healthy diet, low in fats, limited in meats. Get your proteins mostly from a plant source, and try to be active every day. Exercise is the key to life and longevity, I believe. So I think those three easy rules about knowing your doctor, listening to your doctor, having regular follow-ups as directed by the doctor, knowing your numbers, and healthy lifestyle.
Thank you so much. I think that's good advice. And if you don't mind, we're going to end our chat and hopefully have you back. But it was really a pleasure and quite an eye-opening and educational experience for you to join us today.
Thanks, David.
Thank you, Dr. Gurbel. We've been talking to Dr. Paul Gurbel. He is the director of the Center for Thrombosis Research at Sinai Hospital of Baltimore, part of LifeBridge Health System. And a lot of good advice, a lot of world-class research taking place. And please feel free to follow up with him if you'd like some additional information. Dr. Gurbel, thank you again.
Thank you very much.